Today, we're diving deep into the core concepts of hypertension. Now, this is a condition pretty much all of us have heard of, but its inner workings are incredibly complex, and honestly, its consequences can be profound. By the end of this explainer, you're going to have a really solid grasp of the mechanisms, the damage it causes, and most importantly, the strategies we use to bring it back under control.
To really put this into perspective, let's just start with a single, massive number. Globally, hypertension is responsible for an estimated 9.4 million deaths every single year. That figure is just staggering, and it really underscores why understanding this condition is absolutely critical for all of us. This isn't some minor issue. It's a leading driver of the global burden of disease.
So, what are we actually talking about here? Well, formally, hypertension is that sustained, high-pressure force of blood just constantly pushing against our artery walls. But look, this is way more than just a number on a blood pressure cuff. This constant, elevated pressure is a huge risk multiplier. We're talking it effectively doubles the chance of developing a whole host of cardiovascular diseases, everything from heart attacks and strokes to kidney failure.
All right, so to get the full picture, we've broken this down into 5 key parts. We're going to start with the sheer scale of the problem. Then we'll dive into the biological engine that's driving all that pressure. From there, we'll see what happens when the body is under that kind of constant strain, look at how we can regain control, and then we'll finish up with the most critical clinical takeaways you need to know. Okay, so to truly understand this global threat, we have to start by defining it with some clear, hard numbers. That means getting a handle on a specific thresholds that classify blood pressure all the way from normal to dangerously high. So, this is the modern classification for adults. Normal is what we all aim for, less than 120 over 80. But I want you to notice that elevated category. That's kind of like a warning zone that tells us things are headed in the wrong direction even before we call it hypertension. The real trouble starts when we hit stage 1 and stage 2. A systolic of 130 or higher, or a diastolic of 80 or higher, that's enough for a stage 1 diagnosis. And that "or" is so important to remember. Only one of the numbers needs to be in that hypertensive range. All right, now that we've defined the problem, let's pop the hood and take a look at the body's own pressure engine. What are the core biological systems that are supposed to regulate blood pressure, and how can they go into overdrive? You know, at its most fundamental level, it all comes down to this one simple but really powerful equation. Arterial pressure is just the product of 2 key things: cardiac output, that's how much blood your heart is pumping out, and peripheral resistance, which is basically how much your arteries are squeezing against that blood flow. If you increase either of those without a drop in the other to compensate, your blood pressure is going to go up. Simple as that. So what's actually controlling those 2 variables? Well, it really boils down to 3 main systems. First, you've got your intravascular volume. That's just the amount of fluid in your blood vessels, and that's heavily regulated by your kidneys and how much salt you eat. Second is the autonomic nervous system. Think of it as your body's rapid response, fight or flight system. And third, and this is a big one, is a powerful hormonal cascade called the renin-angiotensin-aldosterone system, or RAAS for short. Okay, let's walk through this RAAS cascade, because it's a cornerstone of blood pressure regulation and a major target for our drugs. It all starts in the kidney. When the kidney senses low pressure, it releases an enzyme called renin. Renin then finds a protein from the liver and converts it into something called angiotensin-1. Next, an enzyme called ACE, angiotensin-converting enzyme, transforms that into the real star of the show, angiotensin-2. This molecule is an incredibly potent vasoconstrictor. It squeezes arteries hard, cranking up that peripheral resistance. But it doesn't stop there. It also tells the adrenal glands to release aldosterone, which then tells the kidneys to hang on to salt and water. This increases blood volume and therefore cardiac output. See, it's a dual-pronged attack designed to drive blood pressure right back up. Now we understand the engine. But what happens when that engine is just running too high for too long? Well, the constant strain of hypertension isn't something the body just shrugs off. It inflicts serious, progressive damage on some of our most vital organs. This relentless high pressure is like a battering ram against the delicate inner lining of our blood vessels, and the damage really tends to concentrate in 4 main areas: the heart, the brain, the kidneys, and of course, the peripheral arteries themselves. Let's take a look at each one. For the heart, the problem is simple: overwork. Pushing blood against high resistance is like making your heart lift a heavy weight with every single beat, 24/7. To cope, the left ventricle, the heart's main pump, it adapts by getting thicker and more muscular.
We call that left ventricular hypertrophy. But over time, that thickened muscle actually grows stiff and inefficient, and that paves the way for heart failure. This makes it crystal clear why heart disease isn't just a risk, it's the #1 killer in patients with hypertension. In the brain, the consequences are just devastating. That high pressure weakens the walls of the arteries in the brain, making them prone to either bursting, which causes a hemorrhagic stroke, or blocking off, which causes an ischemic stroke. In fact, hypertension is the single strongest modifiable risk factor for having a stroke. And it's not just about those catastrophic events. Over time, that chronic high pressure also damages the brain's tiniest blood vessels, contributing to cognitive decline and vascular dementia. The kidneys are a particularly tragic target because they end up being both a cause and a victim of hypertension. The high pressure hammers their delicate filtering units and the small arteries that supply them. This leads to scarring or nephrosclerosis and causes protein to start leaking into the urine. And this creates a vicious cycle. As the kidney function gets worse, it gets harder for them to excrete salt and water, which in turn drives the blood pressure even higher, which just accelerates the destruction. It's a terrible feedback loop. Okay, I know understanding the damage is pretty sobering, but the really good news is that we can take back control. This next section is all about how we do that, starting with an accurate diagnosis and then moving to a multifaceted approach to management. You know, a single blood pressure reading in the clinic can be really misleading. On one hand, you have what we call white coat hypertension. That's where a patient's blood pressure is high in the clinic, probably due to anxiety, but it's perfectly normal at home. This carries a lower risk. But far more dangerous is the exact opposite, masked hypertension. This is when the pressure looks great in the office, but is actually high throughout their daily life. These patients have a risk that's similar to those with sustained hypertension, but they often get completely missed. And that is why out-of-office monitoring, whether it's with a home machine or a 24-hour ambulatory monitor, is just so crucial for an accurate diagnosis. For every single patient, treatment begins right here. Before we even think about medication, or at least alongside it, these lifestyle modifications are the absolute foundation of management. Maintaining a healthy weight, adopting that DASH-style diet, cutting way back on sodium, getting regular aerobic exercise, and moderating alcohol. These are all evidence-based interventions that can have a truly powerful effect on blood pressure. Now, when lifestyle changes aren't quite enough, we turn to pharmacology. This table sums up 3 of the major workhorse drug classes we use. First, thiazide diuretics. They work on the kidney to help excrete more salt and water, which reduces blood volume. Then we have the RAAS blockers, our ACE inhibitors and ARBs, which go right after that hormonal cascade we talked about. A huge benefit of these is their protective effect on the kidneys, especially for patients who also have diabetes or chronic kidney disease. And finally, we have calcium channel blockers, which relax the blood vessels to lower that peripheral resistance, and they're often highly effective, especially in older individuals. So let's pull all of this together. What are the most important high-yield points for clinical practice? What do you absolutely need to remember when you're managing a patient with hypertension? Here are 5 critical takeaways. First, for your high-risk patients, those with known cardiovascular disease, the goal is aggressive. We want them under 130 over 80. Second, lifestyle changes are absolutely non-negotiable. They are the foundation. Third, expect to use combination therapy. Most patients are going to need at least 2 drugs to get to their goal. Fourth, always remember the unique benefits of RAAS blockers for patients with kidney disease or diabetes. And finally, if a patient's blood pressure isn't responding to 3 or more drugs, you need to start hunting for an underlying secondary cause. So, as our arteries tend to get stiffer with age and disease, blood pressure naturally starts to rise. And this brings up a really fascinating question for the future of treatment. Should we keep our primary focus on just lowering the pressure number itself, or should our next frontier be developing therapies that directly treat the vessel wall to actually improve its elasticity? It's a question that will undoubtedly shape the next generation of hypertension management.